Hi, I'm Dr. Amy Krambeck. I am a professor of urology at Northwestern Medicine in Chicago, and I'm also the division chief for the Division of Endourology and Stone Disease, as well as the fellowship director for the Endourology Fellowship. Today, I will be presenting a case of complex stone disease and very difficult anatomy. This is a case of a 44-year-old woman with a history of spina bifida. She's a longstanding patient of mine, and I had previously treated her in 2018 for stone disease related to recurrent Proteus infection. As a child, she had undergone a cystectomy with ileal conduit, but had done really well from a urologic perspective, other than the recurrent stones and UTIs. She recently had developed recurrent UTIs, and a CT scan was performed, which demonstrated quite a few stones in her left kidney, as well as a large stone in her right kidney. On this scan, I think it's easiest for me to visualize here. You can see that her left kidney is very rotated over the spine, and her right kidney is more posterior with a larger stone in it, as you can see right here. So I knew this would be quite difficult, but thought that I could potentially treat the left stone ureteroscopically and then treat the right stone percutaneously, which is what I had done in 2018, and she had recovered quite well. So after appropriate antibiotics and culture-specific directed antibiotics towards the Proteus, I listed her for a left ureteroscopy, right percutaneous nephrolithotomy. This is just endoscopy from the conduit. You can see that her ureteral orifice was very difficult to find. I was eventually able to find the left ureteral orifice right around this corner here, up to the left-hand part of the screen, and was able to get a sensor wire into this ureteral orifice and up into the kidney. Once I got the wire in place, I could do a retrograde pilogram and then get an access sheath up. I like to use a more flexible access sheath, an 11-13 sheath, just to allow easy entry in and out of the kidney and to decrease pressures in the kidney as I'm doing the ureteroscopic case. So once the wire was in place and the access sheath was in place, I was then able to get my ureteroscope up into the kidney. Most of the stones were small fragments, so I was able to basket out these fragments. Some of the larger fragments I displaced up into the upper pole and then lasered and basketed, but the left side went very well. I was never able to identify the right ureteral orifice in the conduit. So in order to do the percutaneous portion of the procedure, I converted the patient prone after the ureteroscopy. And then using fluoroscopy, I was able to access onto the stone using triangulation technique. You can see the stone is right here, and I simply placed the needle on the stone and then did my access into the lower pole and put a 24 French access sheath into that area. I immediately was able to identify stone, which was, again, that fragmented type stone. All of the stone material grew struvite and Proteus, so it was good to get her completely stone-free. And I removed the stone using the Trilogy lithotrite. It was very soft and was quickly and easily removed with this device. After all the stone material was removed with the Trilogy, I then did a complete inspection of the entire kidney using a flexible nephroscope to ensure that there were not any fragments or anything abnormal. I like to use pressurized irrigant during flexible nephroscopy because it will allow you to flush out fragments as you look through the kidney and rid the kidney of any small little pieces out the sheath. Once it was entirely clear, I placed a nephrostomy tube and we got a postoperative CT. We did a great job clearing her postoperatively on the scan. She just had a small amount of debris on the ureteroscopy side and was stone-free on the PCNL side. So we took her tube out the next day and was able to send her home on a week of antibiotics. And she was very grateful. There was no episodes of sepsis, and hopefully we can do close follow-up to prevent any further large stone events. So thank you for allowing me to present this difficult case. And you can see that you can do both your ureteroscopy and percutaneous nephrolithotomy at the same time if warranted, and it can be safe and effective for these difficult scenarios. Thank you.